Okay, so narrated lecture number 2, drugs affecting the endocrine system, specifically talking about thyroid medications. Similarly with the thyroid medications, similar to when we talked about the corticosteroids, if you understand how the system works, then we're just basically talking about either supplementing here, or we're talking about trying to reduce, and I might point out reducing thyroid hormones. And we see something very similar here than we saw with the similar to what we saw with corticosteroids, where we see the hypothalamus talking to the pituitary, and then the pituitary talks to another gland. In the steroids, we saw that the hypothalamus talked to the pituitary, and the pituitary then talked to the adrenal cortex down here. But then we see up here, when we talk about the thyroid system, hypothalamus is talking to the pituitary and then talks to the thyroid. And again, we have stimulating factors that are released at each point to stimulate the release. And similarly as well, the amount of T3 and T4, or otherwise known as the thyroid hormones, will feed back upon the pituitary and will feed back on the hypothalamus. And when we talk about those thyroid, those normal endogenous thyroid hormones that are produced, we see that the thyroid produces thyroid hormone, and the major ones are called thyroxine T4 or triiodothyroxine, which is T3. Basically, T3 and T4 are the major ones that we will be talking about and concerned about for pharmacology. T4 is the major hormone that's secreted by the thyroid follicles. T3 is, and then what happens is T3 is formed at the target tissue and by a conversion of T4 to T3. So we see that T3 is the active version of it, but we see T4 is converted from T4 to T3. The body secretes mostly T4. So if you're having a thyroid issue where you're hypothyroid, then you're having a problem secreting a lot of this. At the target site, this T4 is converted to T3, and then the T3 has causes its effect on the target tissue. The body does not produce a lot of free T3. And the other thing is the parafollicular cells, also the thyroid, also produce calcitonin. So that's something else that you have to be aware of when we're talking about issues with the thyroid as well. Thyroid hormones, so the T3 and T4, affects all the cells of the body except adult brain, specifically adult brain, spleen, testes, uterus, and the thyroid itself. So that's a good portion of the body, except for your brain, spleen, and your reproductive organs. It really doesn't, it works on everything else. T3 and T4 have the same physiological effect and regulate the body's metabolism. So metabolism, it's either too high or too low. If you remember that, then you can't go wrong with the symptoms you'll have to look for overproduction or underproduction of thyroid hormones, or the overdose or underdose of thyroid medications. So what do they do? Well, they increase cellular metabolism. So if you increase cellular metabolism, think back to 1016, thinking about how a fever occurs, the metabolism is increasing. So what happens in a fever? Your temperature goes up, hot, hot, hot. So if your thyroid is causing an increased metabolism, then you're going to have increased oxygen consumption and you're going to be hot. Your temperature is going to go up. Along with that, the heart rate's going to go up, cardiac output's going to go up. The metabolism, or the breakdown of carbohydrates and fats to fuel this increased metabolism rate, is going to go up. And what's going to occur as well is the only thing that's going to go down is an inhibition of the secretion of thyroid stimulating hormone. Okay? Why? Because you're producing a lot of it and you're having the effect that you want, so why are you producing more? So it will have an inhibition effect on it. Calcitonin also regulates metabolism, so calcitonin will then lower blood calcium levels and it will have a bone sparing effect. Thyroid gland has the ability to store this hormone, which is quite interesting, has the ability to store the hormone in large amounts for up to 2 to 3 months. So your thyroid doesn't have to be producing 24/7. Okay, it just needs to make it when it needs to, and then it can use its stores as well. And most of the T3 and T4 transported via blood-brain carrier proteins, particularly thyroxine binding globulins. And these can be measured. These can be measured as protein-bound iodine. Iodine is important to these thyroid drugs, or to the thyroid. T3 and T4 bind to the target tissue. What we find as a difference between T3 and T4 is that T3 binds 10 times more readily to the target tissues and can be converted from T4 to T3. So the concentration of free thyroxine in the plasma is the following. T4, you're going to see a lot more T4 because it's got a long half-life and is not bound as much as the T3. The T3, because it's bound and has a low half-life, you're not going to see as much in it. So the 75 to 100 you're going to see as a level of T4, and T3 level should be 1 to 1.2. This is important because guess what? If you start seeing levels lower than this of T4 and levels lower of this of T3, you're hypothyroid. If you see levels higher than this, then you're hyperthyroid. Thyroid hormones, like steroids, also enter the target cells, and they bind to receptors in the nucleus. So this is something it has in similar with the corticosteroids. It also likes to go to the nucleus as well and have its reaction on the transcription of messenger RNA. And thyroid hormones also are, like I said, regulated by that negative feedback network, similar to what is happening in the steroids. The decrease of thyroid hormone can result in inadequate secretion of thyroid-stimulating hormone, and the elevation of thyroid-stimulating hormone can be caused by pituitary tumors that can cause hyperthyroidism. So what does this mean? So when are we going to see people going hyperthyroid? Probably when the pituitary is not working the way it should. The pituitary specifically has a tumor, something malignant that is creating too much of the stimulating factor, will then act upon the thyroid, and the thyroid will do what it's told. If it's told to produce a lot of thyroid, T3 and T4, it will produce a lot. So this is where we see pituitary tumors as one of the major culprits of hyperthyroidism. So also thyroid release triggers of when we have factors that actually inhibit thyroid release. There are some things, for example, somatostatin, and also increased glucocorticoid level. Oh, look at those silly corticosteroids are doing as well. They can also inhibit thyroid release as well. We will see excessively high, and also this is the interesting part. Excessive high levels of iodine inhibit thyroid release. Now this is interesting because you actually need iodine to produce the thyroid hormones of T3 and T4, but if you have too much of the free iodine floating around in the blood, it will have a negative effect on the thyroid and it will tell it to stop making any more. Where we see something in particular, myxedema, which is basically full-blown hyperthyroid syndrome, this is where you're not producing any thyroid whatsoever. So this is just not being hyperthyroid, this is being really, really, really hyperthyroid. You will have a low metabolic rate, feeling chilled, constipation, thick, dry, puffy eyes. You'll have edema, lethargy, and mental sluggishness. Now there is something, now you take myxedema, and if it's due to specifically not something wrong with your thyroid, but something wrong with the precursors to making T3 and T4, which is the iodine, then what ends up happening is you will have what's called goiter myxedema. Okay, what that is, so your thyroid is working perfectly fine, but it doesn't have all the components to make the T3 and T4. One of the components is being iodine. And if we now go in the opposite direction and talk about the hyperthyroid, we see what's called Graves' disease. And it is characterized by too much thyroid stimulating hormone, and is also, you will see high levels of thyroid hormone in the body, in the plasma levels. You'll see the opposite effect, where you saw with the myxedemia, where you're actually seeing the person having a low metabolic rate, being cold. What you'll see here is in somebody who has Graves' disease, elevated metabolic rate, high temperature, sweating, irregular rapid heart rate, nervousness, weight loss. The person who has the myxedemia will have weight gain. Okay, so just know the difference between the two. The one way you can think about it is if you have any sort of myodexemia or hypothyroidism, you have a little bit of time to work with this person. They're not going to die immediately unless they're really, really, really far along. But if you have something where, for example, in Graves' disease, where you have very, very high levels of thyroid hormone, this person can cardiac arrest and go into coma. So let's look at hyperthyroidism and when it occurs. And this is basically, we said, when the thyroid is no longer able to produce any sufficient thyroxine. Possible causes can be lymphatic thyroiditis. So basically we're talking about when we talk about a lymphatic thyroiditis inflammation, we're talking about Hashimoto's disease and some sort of autoimmune disease which is attacking the thyroid. If it attacks the thyroid, then it's unable to actually unable to actually produce the thyroid hormones that you need it to. Now, unfortunately, the other thing that can cause hypothyroidism is the treatment for hyperthyroidism, as you'll see in some of the cases, as we're going to talk about in a couple of slides. The treatment for hyperthyroidism is sometimes the destruction of the thyroid and removing of it. And if it's gone, then where are you going to get the thyroid hormone from? Well, you're going to be hyperthyroid. You're going to be hypothyroid after you've gotten treated for hyperthyroidism. And what we do see is that being able to treat somebody for hypothyroidism is much more controlled and easier than to leave a diseased thyroid in place and trying to treat somebody for hyperthyroidism. It's much more dangerous to be hyperthyroid than it is hypo. And along with it, any sort of thyroid surgery that has to happen as well might also lead you to being hypothyroid. And also, not particularly indirectly, not just the thyroid itself, but if you have a failure in the pituitary gland, and for example, if there's a failure to release thyroid stimulating hormone, the thyroid will be perfectly able to produce it, but not getting the signals, not getting the orders from the pituitary gland to release it. And the other thing, as we just said, with the goiter myxexia, it's basically thyroid iodine insufficiency or an iodine deficiency can also cause hypothyroidism. Hyperthyroidism, thyroid toxosis, is also a condition which the gland is overactive. This also falls in with Graves' disease. So there's three terms that go together: hyperthyroidism, Graves' disease, and thyroid storm. All of those, each one of those three are basically overproduction of thyroid hormone. The way to think about it is hyperthyroidism can lead to a thyroid storm, which can put you in a grave condition. Think of it that way. All three of them are similar. So in the case where you're producing too much thyroxine again, and you're going to have an enlarged gland, you're going to have increased metabolism. Possible causes, again, here we go over and over and over again. Everything is due to autoimmune disease. Sometimes some benign tumors can cause overproduction as well. Can cause after a viral infection as well. Multimodal disease basically means wide stem systemic diseases that will eventually affect your thyroid as well. Thyroiditis and an inflammation. So as we've seen here, an inflammation can actually cause it to be hypothyroid, and it can also cause you to be hyperthyroid. Depends on what kind of inflammation you have going on. And in particular, pituitary tumor or a thyroid cancer can cause hyperthyroidism. Now, the thyroid storm is slightly different than the Graves' disease. The Graves' disease, you can think of something creeping where you're constantly producing too much. But a thyroid storm is characterized by a sudden release of too much T3 and T4. So it's like all of a sudden, all at once. You're doing fine today, and then tomorrow you've got too much T3 and T4. It's a rare condition of hyperthyroid. It's a rare condition. The person will have tachycardia, fever, dehydration, Heart failure and coma are the two big nasty things that this can cause. This is why you want to be able to treat this thyroid storm very, very quickly, because you don't want the person to cardiac arrest on you or go into a coma. That would be bad. We usually see this in patients who have pre-existing hyperthyroidism and who have been treated inadequately, or in addition have undergone some sort of surgery or infection. Now, the drugs for hypothyroidism. Let's split it up into hypo and a hypo. For hypothyroidism, this is pretty much going to be very simple. The goal is replacement, 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 replacement. That's pretty much it. And the big drug of choice that we have is that we like a lot, and you've probably all given it already to some of your patients, is levothyroxine, or what we call Synthroid. It is a synthetic preparation of T4, and it is bound in the plasma protein, has a half-life of 6 to 7 days, and sometimes 9 to 10 days when you are recovering from hypothyroidism. It's a drug of choice because it has a longer duration of action, and it has 2 to 3 weeks duration. It works longer than this other one called levothyroxine. And it's primarily because it's a long duration, because what we just talked about with T4 before. T4 takes longer to break down. It has a longer half-life, so a synthetic preparation of T4 will have the same. This other stuff called levothyroxine, okay, is basically T3. So you've got the levothyroxine, and then the levothyroxine is basically T4, and then as well T3. It has more rapid onset, shorter duration, and therefore really it's not good for long-term treatment. They might use it for a short specific treatment, but it's not used as frequently. And there's another one that has a combination therapy, which is lithotrix or lithox, which contains both T3 and T4. So this one is actually a combination therapy. Thyroid doses for your thyroid, the doses that you usually need of levothyroxine is usually about 60 to 120 milligrams daily. And for myodexia or hypothyroidism, we can see an initial dose of about 15 milligrams in an older adult, sometimes 7.5 to 15 milligrams daily. And then it can be increased or decreased PRN as the patient either gains or loses weight. Adverse effect, dose-related. Okay, the levothyroxine is a potent hormone, maybe cardiotoxic in people with pre-existing heart disease, so not one that we want to use a lot of. Adverse effects are of thyroid hormone or overdose of it is the same as oversecretion that we saw with hyperthyroidism. Okay, so it will cause the same sort of thing. So you're looking for the same side effects for toxicity in with thyroid drugs as you would see in hyperthyroidism. So there might be some chest pain, all the signs and symptoms for hyperthyroidism if the dosage is high. So your nursing implementation and things you should look for hypothyroidism. Monitor apical pulse, apical, and BP periodically during treatment. Monitor also for chest pain in the patient, specifically anybody who has a pre-existing cardiovascular disease. I have put this in bold and in brackets. It's going to be somewhere on your test. You cannot change a medication dosage, but as an RPN, you can hold a medication. So withhold drug if the resting heart rate of a normal adult is greater than 100, specifically in an adult. If it is greater than 100, resting, hold the drug, notify the physician. Okay? Don't give the drug. Don't give them half of the drug. Hold the drug, notify the physician. And also report any changes in heart rhythm, not just the rate, but the rhythm, if there's any abnormal rhythm. So an ECG might actually be appropriate in these situations. Administer early in the day to avoid insomnia, okay, because it is going to increase your metabolic rate. So do you really want to have your metabolic rate in your patients going up when it's time for them to go to bed? No, because then they're going to be keeping you up all night. Monitor for signs of hyperthyroidism, all the signs and symptoms, monitor for those. Monitor diabetic patients for the development of hyperglycemia, so similar to corticosteroids, it will cause hyperglycemia as well. And because if we want to give it at, it's best taken in the morning, also on an empty stomach to obtain best absorption. Some foods will interfere with it as well. So not only in the morning to avoid insomnia, but in the morning, empty stomach. And as I said, monitor for all those signs of tachycardia, anxiety, weight loss, abdominal cramping, diarrhea, fever, cardiac arrhythmia, all those things that will happen with hyperthyroidism. Watch for that. In particular, antacid and iron supplements should be taken about 2 hours after these agents to avoid weakening the thyroid medications. They will interact and decrease the absorption of it. And also educate the patient on, if they miss a dose, take a dose right away. If they miss more than 2 doses, then call your doctor or health professional, because they might have to do an adjustment. 1 dose missed, take it right away. Continue with your next dose as regularly scheduled. You miss 2 dosages, then you need to call your physician or your healthcare professional. They might actually give you a new loading dose, or change the initial dose that you take to sort of catch back up. All right, some drugs now for hyperthyroidism. The way you want to look at hyperthyroidism and put these drugs into your head a certain way, we're going to use 2 approaches on how you will treat hypothyroidism. The one thing you want to do if you're in hypothyroidism, you want to do one thing: reduce thyroid hormone to a normal level to relieve symptoms. You might also possibly want to remove the offending organ that's causing the condition. You kind of want to avoid the destruction of the gland if you can. If you can't, then you have to remove it. And this leads us to 2 different approaches that you can consider. So if you're going to do all of these things and keep these in mind, there's only really 2 ways of going. You can think of this: reduce circulating thyroid hormone by blocking the synthesis of the hormone. If so, reducing the actual thing that is causing the problem. These are going to be the anti-thyroid meds. They will either inhibit the thyroid or inhibit synthesis of the T3 and T4, and sometimes they block iodine. They block the iodine use within the body as well. So that's approach number 1: reduce the circulating hormone. The second approach that we could use in reducing the effect of hypersecretion is actually reduce the effect of the hypersecretion, by relieving the symptoms. So number 1 here, anything that reduces the actual circulating T3 and T4 is approach number 1. Approach number 2, we're not able to reduce the circulating T3 and T4, but we will relieve the symptoms that it is causing. So 2 different approaches. Basically, what we're talking about in approach number 2, beta blocker, beta blocker, beta blocker. All the other meds we're going to talk about and all the other processes are going to fall under here, which is actually some processes that reduce the circulating T3 and T4. So where does that bring us to? That brings us to the following things. It brings us to the drugs to actually treat the antithyroid. You can use antithyroid drugs, and we can use radiotherapy. We could actually use surgery to actually remove the offending thyroid. Beta blockers in general are used as a second approach that we can be used. Or we can use block and replacement therapy, where we basically high doses of something called methazomol is given to block the thyroid gland, and then thyroxine is then added to actually supplement the thyroxine when it falls below normal. The specific agents, and notice I put up here approach 1, approach 1. So what are we doing? These are things that we're going to reduce the circulating T3 and T4 somehow. PTU, or prothiouracil, is a prototype of a thiamide antithyroid drug. What it's doing is it prevents, it doesn't matter how much thyroid you have in your system, it will prevent the inclusion of thyroid in the peptide structure of the hormone. So it prevents you from using iodine in the manufacture of T3 and T4. They primarily like to use this preoperatively if you're going to go in and do a thyroidectomy or to treat a thyroid storm. So PTU is good for a thyroid storm. The effect sometimes takes days or weeks to occur because it does not affect the release of new and stored thyroid hormone. It only affects the release of new hormone It doesn't affect the stored hormone, because remember, you can store T3 and T4 in your thyroid, but if this drug, the PTU, is preventing the creation of new T3 and T4. So remember how much you could actually store. Sometimes for weeks you could store enough thyroid hormone. And if your body's releasing, it's not going to do anything to reduce the thyroid hormone that's already there, but it will prevent the creation of new thyroid hormone. Adverse effects, basically the treatments are the same as hyposecretion. Too much of it, you could go hypothyroid. This one here, tapazole. This is the most commonly used drug and inhibits the formation of thyroxine and reduces its level to normal over a 4 to 8 week period. Has a mild side effects, nausea, vomiting, skin rash, or headache. So this is the one we like, that because think of this as a nice, slow, gentle reduction. It doesn't do anything too rapidly. Patients on this medication should also be monitored for early detection of bone marrow suppression. So unfortunately, even though it's nice and slow, it will cause your bone marrow to be suppressed as well. Some of the adverse effects we're going to see are skin, blood issues as well, agranulocytosis, leukopenia, thrombocytopenia, hypothyroidism if you have too much of it, some gastric irritation, and you have to limit the intake of your iodine drugs as well. So it's the most commonly used, but it's got some negative effects as well. Now, if I were having a if I was having hyperthyroidism, short-term treatment of hyperthyroidism, what we would use, instead of using the PTU, what we would use something called strong iodine solution, or basically Lugol's solution. It's an iodine preparation that's used for short-term treatment. And remember what I said before, that if you have too much iodine, it will have the reverse effect on your thyroid. It will prevent the release of the thyroid hormones. So too much iodine will tell the pituitary, stop making the release factors. Those release factors will stop telling the thyroid to release T3 and T4. So that's what you want. So you can you're still storing, if you have T3 and T4 and thyroid hormones stored in your thyroid, it will stay stored, because this stuff here, strong iodine solution, will tell the pituitary, don't release anymore. The pituitary will stop making precursors. The pituitary will then stop telling the thyroid, stop releasing. So it inhibits that release of thyroxine when given in high doses. The effect only lasts a few days, but that could be the difference between life and death for somebody who is in a thyroid storm. And it is basically, Lugol's solution is basically potassium iodide. And the other thing it does, which is kind of nice, is it actually increases the vascularity and firmness of the thyroid. It actually makes it easier for surgery. So you might even see this prior to surgery for somebody who has hypothyroid as well. Now, another way to get rid of the circulating thyroid hormone is just to destroy the thyroid. And if you don't want to go for surgery, one way to do it is using this stuff called sodium iodine 131. 131 basically means this is a radioactive isotope, because iodine is pretty much only used by the thyroid. When you put a radioactive isotope in it, guess what organ is going to absorb it? The thyroid. The thyroid absorbs it, and unfortunately, it cannot recognize, and this is the interesting thing about radioactive treatments, the body cannot tell the difference between regular, simple, non-radioactive iodine or the radioactive version. That's why the body still absorbs it. The thyroid does not know that this iodine 131 is radioactive. It's that stupid. It just doesn't know that this is going to cause problems. So it absorbs it, tries to use it like regular iodine, and unfortunately what happens is the radiation then actually wrecks the thyroid tissue. It's usually given oral or IV. It's taken up rapidly by the thyroid gland, so you don't have much to worry about causing issues to other cells around. And it basically reduces functional thyroid tissue, and then can lead to entire destruction of the thyroid gland, and that's usually the goal. The adverse side effects of iodine 131, is it can lead to hyperthyroidism. And unfortunately, you have somebody now who is taking a radioactive substance, so they have to be isolated from other patients. And then you have to follow any radioactive protocols that are required by your institution. Another approach, still using approach 1 here, reducing the circulating volumes of thyroid hormones. There's this thing called caperchlorate. It's something that gets concentrated in the thyroid, blocks again the uptake of iodine in the thyroid gland, and decreases thyroid production. Unfortunate effects of this, it can cause aplastic anemia, so that can be a nasty effect as well. The approach number 2, the only approach for number 2, beta blockers, beta blockers, beta blockers, beta blockers. It has no effect on the circulating thyroid concentrations. They only block the symptoms, and here we have propranolol, metoprolol, and natadol. Propranolol, in addition to blocking symptoms, also blocks some conversion of thyroxine T4 into T3. So the propranolol, guess which one is going to be used? Want to be used a lot of? This one right here, because it not only does it stop us to having the bad symptoms that could put us into cardiac arrest or to put us into a coma, but it will also have a little bit of effect on some of the circulating T3. It's used as an adjunct therapy, usually prior to surgery, prior to removing the thyroid gland, and it can actually suppress signs and symptoms of hyperthyroidism, which is that tachycardia, tremor, and anxiety. Adverse effects of these beta agents: bradycardia, so giving too much of it, you're bringing down the heart rate, you can go too low. Cardiac failure, yes, you can die of cardiac failure from having too much of the T3 and T4, but if you give too much of the beta blockers, you can also go into cardiac failure. Hypotension, bronchospasm, constipation, you can have some cold extremities as well, fatigue, and some sleep disturbances can come from these beta blockers as well. And with your nursing assessment and implementation of drugs for hyperthyroidism, then you basically want to know each patient receiving it. You must know the signs and symptoms of thyroid disease, because you have to assess the degree of how badly they actually are. Assess how bad the signs and symptoms of thyroid disease are. Those are going to be your benchmark to see whether or not the treatment is working. During treatment, blood levels can also be done, so you can actually see how much T3 and T4 is actually circulating, and they will vary from low to high depending on what stage of treatment that you're in. And observe patients again for signs and symptoms when blood levels are too low. If you're going towards the direction of destroying the thyroid using sodium 131, then you should see blood levels go from T3 and T4 levels going from very, very high to normal to not abnormal. And what's going to happen? Well, now you're hypothyroid and you're going to now supplement. Aggressive treatment can also cause adverse effects, so also watch and observe for signs and symptoms more frequently. And remember, we can also look, as we talked about, we said we could measure T3 and T4. We can also measure thyroid stimulating hormone. So this is the stuff that is coming from the pituitary, telling the thyroid to make more, or release more. And thyroid stimulating hormone is important because it tells you where the problem is. If you have a lot of thyroid stimulating hormone, then and no thyroid hormone being produced, then you know that the problem is in the thyroid. Okay, the pituitary is doing its job, trying to stimulate, but the thyroid isn't responding. You're going to have a problem in the thyroid. If the thyroid stimulating hormone is low, but the thyroid hormones are very, very high, then what's happening then? Well, you're pretty much going to know that the problem is still in the thyroid. Okay? If the thyroid stimulating hormone is very, very high, and the thyroid hormones are high as well, then we start looking to a pituitary problem. Okay, you sort of have to see, look, if you go back to the diagram at the beginning of this lecture and look at what is causing what to happen, If you have high thyroid stimulating hormone, that means the pituitary is telling the thyroid, make more, make more, make more. So if the thyroid stimulating hormone is high, that means the problem must be coming, or the major malfunction must be in the pituitary. If you see thyroid stimulating hormone levels normal, but the outcome coming from the thyroid is either hypo or hyperthyroid, then you know the problem is in the thyroid. Okay? And this is why this is why doctors, when they're trying to diagnose, do thyroid stimulating hormone levels, and they also do free T3 and T4 levels as well. And that's why we say elevated thyroid hormones, the first signs of primary hypothyroidism, which means it is coming from the pituitary. Nursing interventions that we would include in doing some of our assessments, always temperature regulation, because we're talking about metabolism. Temp's going to go too high or go too low, or it's going to start off high and go low depending on our treatment. Diet, you're going to either be hungry because your metabolic rate is too high, or you're going to be, for hyperthyroidism, it's going to be high. Fluid regulation is going to be an issue, physical activity level, and skin and eye care as well.